This is Sally Schessler, Director of Education for Allergy and Asthma Network. Welcome to Advances in Allergy and Asthma, a webinar series that helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. It is presented in partnership with the American College of Allergy, Asthma, and Immunology. Today, we are joined by Dr. J. Wesley Sublett, who will speak to us about chronic rhinosinusitis and treatment options. Dr. Sublett is a partner and medical director of clinical research at Family Allergy and Asthma based in Louisville, Kentucky, with multiple offices throughout Kentucky, Arkansas, Indiana, Ohio, and Tennessee. He is a graduate of St. Louis University for his master's in public health and the University of Louisville School of Medicine. Board certified in both pediatrics and allergy immunology, Dr. Sublett completed his internship and residency in pediatrics at University of Louisville Kozar Children's Hospital. He completed his fellowship in allergy, asthma, and immunology at the University of Cincinnati. Currently, Dr. Sublett serves on the college's Board of Regents, president of the Greater Louisville Allergy Society, and the chair of the American College of Allergy, Asthma, and Immunology Drug and Anaphylaxis Committee. Dr. Sublett, thank you so much for being with us today. We're looking forward to what you have to say.
Thank you, Sally. Thank you, everybody that's on today. It's obviously a monumental day with the FDA considering the Pfizer vaccine, and I've spent most of the morning watching that. So again, thank you for everybody joining me today. These are my relevant disclosures for today's talk. So our objectives today in discussing chronic rhinosinusitis will be the following. We'll be able to define chronic rhinosinusitis. We'll discuss evaluation tools utilized in chronic rhinosinusitis, discuss the medical treatments currently available for CRS, and discuss also surgical treatments that are available for CRS. And due to time, we're going to go briefly through a lot of information today. So let's start off by defining what is chronic rhinosinusitis. Well, chronic rhinosinusitis with or without nasal polyps is defined as the presence of two or more symptoms, one of which should be either nasal blockage or obstruction, congestion, with either discharge, either anterior or posterior nasal drip, along with facial pain or pressure, reduction in smell or anosmia that's been ongoing for more than 12 weeks. This affects about 6 to 12% of the patients we see currently, and really can be divided into two major phenotypes. Those that have nasal polyposis, that represent about 25 to 30% of cases we see with CRS, or those without, which again is the majority of our patients, about 70 to 75%. So phenotypes are very, obviously, they describe the clinical characteristics or traits we see with CRS. But with endotypes are in contrast to phenotypes in the sense that we're really defining the biological subtypes that we see that are cause the pathophysiological mechanisms we see with chronic rhinosinusitis. Biological markers such as tissue eosinophils, IL-5, IL-13, periostin, IgE. These are all very good biologic markers that we look at when we're trying to identify endotypes. And on the screen you have here really a graphic that shows some of the current endotypes that we have described thus far in chronic rhinosinusitis. Some are going to be without nasal polyposis and some are going to be with nasal polyposis. So that's important to keep in mind as we go through thinking about targeted treatments for our patients that have chronic rhinosinusitis. So let's briefly talk about the evaluation of chronic rhinosinusitis. And really this can be divided into really three three really big topics. The first is obviously we all should start any patient assessment with clinical history and physical exam. And I'm not going to talk at length about getting a detailed history or doing an in-depth physical exam on someone we suspect with chronic rhinosinusitis, but I am going to talk about some of the cardinal symptoms we should really be asking about if we suspect chronic rhinosinusitis. So there's really on the screen we can see the four major cardinal criteria, cardinal symptoms we see with chronic rhinosinusitis. The first being nasal obstruction or congestion, the second being nasal discharge, the third being facial pain, and the fourth being either change in sense of smell or anosmia. And this graphic is out of the European EPOS, which is the European kind of consensus statement on chronic rhinosinusitis. And as you can see, the different groups that we see in our outpatient clinic to those that are going to ENT for surgery versus those that our GP colleagues see, they really show the same type of kind of cardinal symptoms across the board with some minor changes between those that have nasal polyps and those that have chronic rhinosinusitis without nasal polyps. Just some minor differences in their cardinal symptoms. One thing I would like to state is that even though facial pain is a cardinal symptom of chronic rhinosinusitis, it is one that is very divergent. There's many causes of facial pain, and really nasal obstruction and anosmia are really key markers that we see for chronic rhinosinusitis. So besides getting a detailed clinical history and really talking to our patients about what cardinal symptoms they are having, really there's some key things that we need to do to adequately diagnose someone with chronic rhinosinusitis. The gold standard really is still the CT scan and the use of the Lundmacke system, which really looks at, it's a validated scoring system for sinonasal inflammatory changes that gives a maximum score of 24 or 12 per side. And what has been shown with chronic rhinosinusitis is that if you have an LMS score of 2 or less, it has a very good negative predictive value that someone does not have chronic rhinosinusitis. However, if you have someone that has a Lundmacke score of 5, it does have a very excellent positive predictive value of someone truly having chronic rhinosinusitis. We should be aware that while CT is the gold standard right now, conventional sinus x-rays are no longer indicated for the evaluation of chronic rhinosinusitis. Endoscopy still plays a very important role in the evaluation of rhinological diseases, including chronic rhinosinusitis. The examination, when we look at the examination using a nasal endoscopy versus CT scans, we are still able to see that there is a good correlation between the true diagnosis of someone with chronic rhinosinusitis between CT and endoscopy. When we're looking for nasal polyps, the scoring systems really are, the scoring system here shows a good example of how it goes from 0, no polyps, to up to 4, which would be something that would be true nasal obstruction. But really we're looking somewhere between grade 0 and 3 when we're using endoscopy, because if you have a grade 4, you're just not getting in the nose. But most of the patients that we can really evaluate greatly with nasal endoscopy are going to be those that have nasal polyp scores of 1 or 2, because it is very hard to, with just a traditional anterior nasal speculum exam, to see anything beyond a very kind of grade 2/3 polyp, and we are going to miss those patients that have grade 1 polyps without the use of a nasal endoscopy. So if you don't have access to a nasal endoscope or an ENT colleague that you trust, again, I would recommend going with that gold standard of a CT scan for evaluation of a patient with chronic rhinosinusitis. So really today, we're going to be talking a lot about therapies. And man, there's been a lot of movements and a lot of treatments development here in the last couple of years. And even recently, in the past couple of weeks, we've had a new approval. And so we're going to start with medical therapies. This is a greatly growing segment in chronic rhinosinusitis. And we're going to start with really what has been kind of the mainstay for the longest time, and that's the use of nasal corticosteroids for the management of chronic rhinosinusitis. So the use of corticosteroids, especially nasal corticosteroids for the management of chronic rhinosinusitis, is supported by high-level evidence, with particularly strong evidence with chronic rhinosinusitis with nasal polyps. Mechanistically, nasal corticosteroids are effective at suppressing the type 2 inflammation that is typically seen in chronic rhinosinusitis, including eosinophils, group 2 innate lymphoid cells, and Th2 cells that are as well as particularly reversing that secondary epithelial damage that we see with chronic rhinosinusitis. So this is a forest plot looking at by the Rhinology EPOS of the European position paper on rhinosinusitis and nasal polyps, and we'll just continue to call it EPOS from this point forward. But it's a meta-analysis showing that nasal corticosteroids are favored over placebo in the improvement of symptoms of both symptom scores and also portion of nasal responders. And this just shows that there's we see responders far greater than those that are on placebo. So nasal corticosteroids have a positive impact on disease, specifically on quality of life with patients with chronic rhinosinusitis. And again, this is from the EPOS, but in studies that evaluated the sinonasal outcome test, also known as the SNAT22, when we looked at a combined meta-analysis, although treatment times were quite different, anywhere from 4 weeks to 24 weeks, nasal corticosteroids were favored over placebo in the improvement of quality of life disease in chronic rhinosinusitis. Nasal corticosteroids also have been shown to improve polyp scores, and a greater proportion of responders over placebos and polyp size reduction was seen in a meta-analysis that was analyzed with EPOS. And nasal corticosteroids, when administered after endoscopy sinus surgery, they do prevent reoccurrence, and they do significantly better than those that are placed on placebo. And so many, as we see here, the risk ratio favors nasal corticosteroids over placebo after nasal surgery. So again, nasal corticosteroids are still really the gold standard that we have for sinusitis, but we have some new tools that are available now that are going to be looked at even greater in the future. And so the first that we're going to talk about today is going to be the exhalation delivery system with fluticasone that uses a novel closed palate mechanism designed to deliver medication to regions that we need to target in patients with chronic rhinosinusitis. And so there is a name brand product that most of us know that by the name of Xhance. And this is going to be the study that was the pivotal study that really shows that there is a difference between fluticasone and using an exhalation delivery system with fluticasone. And so the exhalation delivery system is a new concept for intranasal drug delivery. and it has been shown to deliver substantial fractions of medication past the head of the inferior turbinate and into the superior and posterior regions of the nasal passages, such as the osteomeatal complex. And so, again, this is showing deposition here beyond what we would typically see with a traditional or conventional nasal corcosteroid nasal spray. And the pivotal study was the Navigate-2 study. And in this study, they took patients 18 and older with moderate to severe congestion and nasal polyps, and were randomized into either twice daily exhalation delivery system with fluticasone into either the 93 microgram group, the 186 microgram group, or the 372 microgram group, BID, compared to placebo. And the primary endpoints were really looking at nasal congestion or obstruction at 4 weeks and some bilateral polyp grading at 16 weeks. So what happened to polyps? Well, polyp grade was statistically improved in each of the exhalation delivery system fluticasone groups at every time point from week 8 through week 24. By week 16, 63% to 69% of patients in the exhalation delivery system fluticasone group had achieved a response a greater than 1 point improvement in polyp grade compared to placebo. The polyp elimination rate in at least one nostril increased with increasing treatment duration, reaching 13.6% in the 372 microgram group at week 16 compared with 4.3% with placebo, increasing all the way up to 28.2% at week 24. So what about cardinal symptoms that we discussed earlier with the exhalation delivery system of fluticasone? All 4 diagnostically defining symptoms showed significant greater treatment effect versus placebo. In addition to the primary time point, the differences were significant at all other time points with 372 microgram dose, as well with nearly all time points at lower doses, and this is shown here. Just note that the yellow is the 372 microgram group. So moving on to a different product, that we're going to kind of move on to a biologic that has an indication now for chronic rhinosinusitis with nasal polyposis. We're going to be talking about Filomab. Filomab is a fully human monoclonal antibody that inhibits signaling of interleukin-4 and interleukin-13, which are key drivers in type 2 inflammation. And so they have two key pivotal clinical trials, SNAT22 and SNAT22, that we'll be discussing. So on the screen is the study design for SNAT22. It was a randomization of 1-to-1, and patients were either put in placebo group or the 300 milligram dose every 2 weeks, and were looked at over a 24-week period, after which they were stopped off the medication and followed for another 24 weeks, compared to that of the SNAT22 group, which looked at the Filomab every 2 weeks versus Filomab every 2 weeks, followed by every 4 weeks versus placebo over almost a year period, a 52-week period, and then were followed off treatment for another 12 weeks. And so we'll be kind of showing both results side by side. And so when it came time to look at decreases in polyp size at 24 weeks, the least mean square difference in nasal polyp scores of Filomab versus placebo was that least mean square was 2, with a confidence interval of 2.43 to 1.69 in Sinus 24. And in Sinus 52 is a decrease in, that decrease in mean change was at 1.8 versus placebo for Sinus 52 at week 24. And if you note that with Sinus 52, because of the extension, the mean change, the mean squares difference changed, was continued to be reduced from baseline all the way out to week 52. Well, besides polyp scores, they were also able to demonstrate that dupilumab differences in nasal congestion or obstruction. And so when you look at the mean symptom score reduction versus placebo, those in Sinus 24, there was a 0.89 score difference at week 24 versus those that were on Sinus 52, which was almost it was at 0.87 least mean square difference at week 24, which again continued to improve because of the continued treatment over 52 weeks. With Sinus 24, as you would expect, off treatment after a period of time, after week 32, there was an increase in closer to baseline off of treatment with nasal congestion. So one of the important things about using a biologic with dupilumab is, can we reduce a patient's exposure to systemic steroids, or can we delay the time to sinus surgery? And so with dupilumab, they were able to show that there was a 74% reduction to time of systemic steroids versus an 83% reduction over time with surgery. And so there was a significant difference between those that were on placebo versus those that were on dupilumab. Now, here in the last couple weeks, omalizumab has been approved for the use of chronic rhinosinusitis with polyps. The two pivotal trials that we'll be discussing today are Polyp 1 and Polyp 2. So in Polyp 1 and Polyp 2, there are actually duplicate studies that were started at different times, but they were the same study. So that's why we're going to show this graphic here, that it's the same. And so in Polyp 1 and Polyp 2, adults with chronic rhinosinusitis with nasal polyps with inadequate response to intranasal corticosteroids, one either on placebo or omalizumab after a run-in period. They were going to look at nasal polyp, change in nasal polyp score from baseline, change in nasal congestion score, and also going to look at the SNAT22 score from changes from baseline to week 24, along with some other secondary endpoints. So the key thing with omalizumab is that they did show a significant improvement from placebo in both in both Polyp 1 and Polyp 2 studies. Both studies met their co-primary endpoints, with omalizumab patients achieving statistical significant improvements in both mean improvements in nasal polyp scores and daily nasal congestion scores compared to placebo at week 24. And that's shown here on the screen. The mean changes in nasal polyp scores for omalizumab versus placebo from baseline at week 24 were the polyp score had reduced by negative 1.08 compared to placebo, and the mean changes for nasal congestion had also changed significantly for omalizumab by 0.92% in the omalizumab group compared to placebo at week 4 that was sustained all the way out to week 24. The other thing that is important is SNAT22 is really a score that we use to assess a patient's quality of life as well with someone that has chronic rhinosinusitis. And so there was a significant improvement starting at week 4 in the SNAT22 score with omalizumab compared to placebo. In placebo, we had a -8 point drop versus a negative 10 point drop, a difference in 10 from baseline in SNOT score in the omalizumab group. And this was sustained throughout the clinical trial all the way out to week 24. And so significant improvements in quality of life in our patients that we saw with omalizumab versus placebo. So we have to talk about a special population where we do have treatment for chronic rhinosinusitis, and that's in our aspirin-exacerbated respiratory disease patients that have chronic rhinosinusitis with nasal polyps, asthma, and an intolerance to COX-1 inhibitors. And it's important that they really have those key components because those are going to be the best responders to aspirin desensitization. And shown here on the screen is a study that looked at the aspirin desensitizations followed by high-dose aspirin use and looking at steroid burst, sinus infections, hospitalizations, and also looking at SNOT scores, ACT scores. And what they were able to show is prior, compared to that aspirin desensitizations were able to significantly improve ACT scores, SNOT scores, and overall decrease the use of corticosteroids burst over a year period in those patients that have aspirin exacerbation respiratory disease following aspirin desensitization and high dose aspirin therapy. But really this is a subset or an endotype that we see in our own clinic that this is an option for. So moving on beyond medical therapy, and just to give us time for discussion here at the end, I'll try to allow about 15 to 20 minutes of discussion. But we're going to be talking about surgical interventions. And surgical interventions, obviously, as an allergist, I refer them on to my rhinology colleagues or my ENT colleagues. I'm lucky that I do have a good friend and also a local ENT that is a rhinologist. But, you know, our ENT colleagues have some good tools that they're able to use in the treatment of chronic rhinosinusitis, and we'll discuss those next. But just know that as an allergist, I am more familiar with medical therapies than I am surgical therapies. But it's an important part of our discussion that we have for our patients to talk about what our patients may expect. And so one of the things that has shown great promise is the corticosteroid-eluting nasal implants that can be both placed in the office following endoscopy, sinus surgery, or during sinus surgery. And so the change from baseline to day 90 and bilateral polyp grade shows a significant favoring of corticosteroid-eluting nasal implants compared to placebo, and that patients treating with steroid eliciting implants also had less likely to have a sinus surgery versus those that were on placebo after day 90 as well. So this is a important arsenal that we have for chronic rhinosinusitis with that we can use, because we can really direct the medication with these implants to the tissue that needs to be treated. However, these need to be placed usually during surgery or under endoscopy guidance. Now, those patients that have had polyps are usually, by the time they're seeing an allergist, have already experienced their first functional endoscopy sinus surgery or FUS surgery. And so one of the things that's important to know, especially now that we have new treatments available, is that many of our patients may be a little bit jaded by their prior experiences, because functional endoscopy sinus surgery was really for a long time a gold standard in treating those with nasal polyposis or chronic sinusitis, because really our therapies, medical therapies, were not that good, even though nasal corticosteroids are still kind of a gold standard in treatment. But this really shows that following functional endoscopy sinus surgeries, that there is an initial improvement, especially, so it's not it's going to be looking at SNAT22 scores, but there really is an improvement following surgery for 3 months, at 3 months after surgery. But if you continue to follow someone out for a long period of time, that there usually is a kind of a rebound effect or an increase in chronic rhinosinusitis symptom scores post-surgery. And so many of these patients, as we well know now, will require a revision or multiple sinus surgeries. But hopefully with new novel therapies, we can delay those sinus surgeries and also potentially even prevent them from occurring in the future. So one of the tools the ENT colleagues have available to them that they can do in the office are balloon dilations of the sinus ostia. And this is an important study that looked at, balloon dilation compared to functional endoscopy sinus surgery. And so these were randomized controlled trials they were part of the remodel study, and they were looking at functional endoscopy sinus surgery versus balloon dilation. And when they looked at SNAT20 scores, they were able to show a significant improvement from baseline was observed both in balloon dilation in the office versus functional endoscopy sinus surgery. And so both showed improvements, but standalone balloon dilation was not inferior to functional endoscopy sinus surgery. And then if you did the meta-analysis where they kind of did a combined model of all looking for random effects, both the overall mean SNAT20 change and the mean subscale changes from baseline were significantly improved and clinical meaningful at follow-up points. And so that's shown here in figure 4. And just know that it really shows that, there's other tools, that, especially that our ENT colleagues can do in the office, that may have some long-term effects other than going straight to sinus surgery, such as balloon dilation and using a corticosteroid-eluting nasal implant that may or may not be placed in the office. And so I think we're at about 4:40. I'm going to go ahead and pause here for questions. And so, Sally, I'll turn it back over to you.
Thank you so much. This was just so interesting, and I totally appreciate everything you had to share. Our first question comes from a physician who asks, If long-term Zolair has been helpful for chronic sinus polyposis and severe persistent allergic asthma, how would you decide if any of the newer siblings of Zolair might be helpful?
That's an excellent question. And what I would say at this point is those are under clinical investigation, and because they are not FDA approved, I am going to not discuss those today. But I think that because of mechanistically, we may see similar. It would be hopeful to see similar effects, but we'll have to wait for those studies to conclude. But that's a good question. But we'll have to wait until the studies are published and finished.
Okay, I can answer. The next question is, how do we print the certificate of attendance? If you're listening live to the webinar, you can go to the handouts pane on your control panel and download the certificate from there. Please do it before the webinar concludes, because then you won't be able to access it. And now another question for Dr. Sublett. This one is, does COVID exacerbate chronic rhinosinusitis?
That's a great question. And in full disclosure, I participate in a kind of a group that is a mixture of both rhinologists throughout the country and allergists across the country. That's really an informal group that we have discussions, and we've discussed this a lot, obviously, given the current environment. So what do we know about chronic rhinosinusitis? Well, any viral illness can exacerbate the inflammatory response with chronic rhinosinusitis. And so with the advent of being in the COVID era right now, and the fact that we do see patients that develop not only lower respiratory disease with COVID, but also upper respiratory disease, COVID is going to be a very complex pathogen that we're going to learn more about as time goes forward. But hopefully, given today and the FDA, hopefully we'll have a resolution, or at least a starting point. But the answer is yes, it definitely does seem to exacerbate chronic rhinosinusitis. And so I think what's complicated things is we have patients that have the effects of anosmia, loss of smell. That's a complication of COVID-19. And so that complicates things when we're trying to assess our patients currently, because now we're thinking, okay, is it complication of COVID-19, or is this chronic rhinosinusitis with nasal polyps, or is it just changes in smell? So the answer is, I think, again, I'm getting long-winded for a very short answer. It does exacerbate, just like any viral illness, exacerbate chronic rhinosinusitis.
Okay, that is interesting. We have so much uncharted territory these days to think about. Okay, our next question is, how long does it take to do a balloon dilation, and is it an office procedure?
Yeah, that's a great question, and I will tell you that. That in my experience, that in talking to my ENT colleagues, these are very in-office procedures that they can do while a patient is in their clinic and not in the OR, that most patients have been able to tolerate them. Occasionally, depending on the circumstance or prior surgery, they will take them to the OR for some sedation so they can do a better job. But it's kind of patient specific, but most of our ENT colleagues that I've talked to are able to do it in the office without, it doesn't take very much time.
Okay, thank you. Our next question is, what was the Zolair dose used in the two studies that you cited?
Yeah, that's a great question, and I'm pretty sure it's the. Let me get back to you real quick on that, but I'm almost positive that it's the 300 milligram dose that was used for omalizumab. I'm going to kind of tell myself I'm kind of wiped out because I've been reading material on on the Pfizer vaccine all day, so I've got multiple numbers in my head, and that's not an excuse, but it's for some reason I cannot recall that off the top of my head, but I'll be able to, if I think about it, I'll get back to that in just 1 second.
Okay. Can we go to the next question then? It is, how is the
Sure.
exhalation delivery system done?
Oh, so how is the exhalation delivery system done? That's a great question. So the exhalation delivery system is a specially designed device which is able to kind of what they're able to do is they're able to they put the device in their nose and they put a mouthpiece in their mouth, and what happens is when they blow into the device, that actually raises the soft palate in the back, which actually isolates the sinus cavity, and they depress the device, and that delivers the fluticasone while they're blowing into the device, and it delivers the fluticasone high and deep into the sinus cavities.
Okay, great. Is there data with dupilumab showing polyp elimination during pivotal trials?
Can you repeat that question, Sally?
Sure. It said, is there data with dupilumab showing polyp elimination during, it says, the pivotal trials?
Well, if you look at the dupilumab studies, it did show a greater decrease in nasal polyps compared to placebo. I'd have to go back and actually pull up that specific table that shows elimination, but I believe there was.
Okay. Next question is a very interesting one. Has there been any study on natural plant treatment or essential oils?
Not that I'm aware of. And obviously those would be something that are alternative therapies that really we're not going to discuss today. And so, if you want to talk about, things that are available that are, I guess, would be considered more natural, sinus saline rinses have been shown to show improvement in chronic rhinosinusitis, both in those that have polyps and those that do not. And so that's really, from a non-medicinal standpoint, that's probably the best, I don't want to call it alternative therapy, but that's a non-medical therapy that we can use that has been shown to show some improvement, is just using nasal sinus rinses with saline. And there's been multiple studies looking at not only normal saline, but also hypertonic saline. And they've all shown some improvements when you look at the meta-analysis, and that is in the EPOS documents if anybody is interested.
Okay, great, thank you. The next question is from a patient who has AERD. The person has had nasal surgery and they want to know, what are the chances of their polyps returning?
So what are the chances of someone who has had sinus surgery of their polyps returning?
Yes.
Yeah, the majority of patients are going to have a reoccurrence of nasal polyps within 3 years. And I don't have the statistics in front of me, but I do know that if you look at, repeated sinus surgeries because of nasal polyposis, that a far majority of patients are going to have reoccurrence within 3 years, if not less.
Okay.
So that's one reason that these that medical therapies are really becoming very important for our patients with chronic rhinosinusitis.
I'm quite sure people would not like to go through multiple surgeries if they don't need to. So, okay, somebody asks, can you explain the SNAT22 scores again?
Yeah, so SNAT22 scores are going to be, it's a mixture of scoring that is based on multiple symptoms. I think of it kind of like an ACT score for chronic rhinosinusitis. It talks about anything from things that we would think about in the nose, from like nose blowing, sneezing, runny nose, to more lower respiratory symptoms like cough. It talks about ear fullness, ear pain, facial pain, and then they go into more kind of like more things we would associate with quality of life. So lack of good night's sleep. Are you waking up at night? Are you having difficulty falling asleep? There's a question that says, are you embarrassed? And it's scored from 0 to 5, with 0 being no problem at all, up to 5, which is problem as bad as it can be. And so it's a scoring system. I personally do not use it in my clinic in a clinical setting, because it's 22 questions that are, 22 symptoms that they're asked to score 0 to 5. To me, it takes a lot of time. I do it in clinical research, but I don't do it in my clinical practice. And there's current movement to get a clinical-based scoring system that would be more relevant for the clinic than using the SNAT22, just because it's just a long test. But my rhinology colleagues, they love it. They love it because they'll give it to every patient as they're walking in the door. They have them fill it out, and they can discuss it with them. So it's a scoring system we use a lot more in research than we do in clinical practice.
Okay, great. Next question. Should someone with osteopenia be concerned about bone density issues with its chance?
Well, that's a great question. I think any nasal corticosteroid, just because in the class effect of being a steroid, has some absorption into the systemic system. However, the formulation is different, and I think in their bioequivalency studies, I know that they were able to show that a lower dose was clinically effective than what was used traditionally with fluticasone. So that's something to consider, is even though it's still fluticasone and it is a nasal corticosteroid, they were able to use a much lower dose because of the novel delivery system to treat chronic rhinosinusitis with nasal polyps.
Okay, our next question comes from a patient. It says, what's the difference between a nasal polyp versus a bony spur? I was told I have a nasal spur. Surgery is not needed.
Well, yeah, so a nasal spur is going to be, obviously that involves, it's usually past trauma, where you get some ossification and a little outgrowth of bone. Nasal polyps are also an outgrowth, but think of it more grape-like, and usually those are packed full. They're translucent. They are packed full of eosinophils, and they're like little bitty grapes that are outgrowths of our sinus mucosa. And so because of that, unlike a bone spur, again, I'm not a trained otolaryngologist. I can't talk specifically about surgeries, but obviously, probably in the given the right location, a bone spur could cause some pressure or pain, but polyps regrow because they're outgrowths of the mucosa and packed full of eosinophils. And so generally a bone spur is not going to if it was taken out, it wouldn't regrow, and it also usually doesn't. Usually a polyp is going to be not just one; it's going to be there's going to be many.
Okay. Are there any studies on projected cost of biologics like dupilumab and Xchance or Zolair?
I'm sorry, Sally, you broke up there for a second. Are there any
studies on the projected cost of the biologics like dupilumab and Xchance or Zolair?
Well, so with any biologic, obviously biologics fall into a special category of drugs, and usually they are going to be expensive. As far as comparable studies, I haven't seen any comparable cost analysis looking at the cost of different biologics compared to Xchance. I'm not aware of any.
Okay, great. Thank you for that. Next question is, anosmia has been linked with Alzheimer's. Is CRS linked with Alzheimer's?
I have not seen a study to say it is or is not.
Okay. I thought that was a very interesting thought. Okay. Let's see here. Can you speak to the mechanism of why and how there's a loss of smell and taste that occurs with COVID-19? We're putting you through the ringer tonight, Dr. Sublett.
No, so I was just a bit, okay. So in full disclosure, and I'm sure my wife will be happy to bop me on the head when I get home if she hears this. But so because of our recent experience with COVID-19, not only from a personal level, but also just in discussing it with my rhinology colleagues, I think there's a lot of, at this time, we do not know the mechanism. I've heard that the mechanism has been discussed anywhere from being similar to those patients with chronic rhinosinusitis with nasal polyposis, in the sense that there may be not only some obstruction, but also some cytokine neurotoxicity effects, to anosmia being more central. And I think that the answer is we do not know at this time why there are a subgroup of patients that develop anosmia with COVID-19. And so at this time, I'd say we do not know, because these patients that develop anosmia also have a strong loss of sense of taste, even to things that we shouldn't have loss of sense of taste, and that would be like products that contain capsaicin. And so I think that brings in the question, why are we seeing patients that lose their sense of taste and smell, and also in COVID-19, because they should be able to at least feel the capsaicin.
We have so much, don't we? I think we're going to be learning about COVID for a long time.
Well, I'm hoping that, I'm hopeful that we have some better resolutions here.
I think we would all applaud that. So, Dr. Sublett, we're so grateful for your time with us today. Thank you so much. And I'd like to thank our listeners for joining us today as well. So at this time, please download that certificate of attendance from your control panel. If you have any difficulties, please email us using the link in your emails. You can join us next month, please, for our January 2021 webinar when Dr. John Kelso will present on vaccines and vaccine hesitancy, how to improve respiratory outcomes. This webinar will air on Tuesday, January 26th at 4 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for news in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our recorded webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network, wishing you a happy and a peace-filled holiday season as we work to breathe better together.